Now I would call upon Dr. Mallikarjun Heralgi for his talk on Acanthameba keratitis. So we all know that Acanthameba has a very different profile in the West versus what is seen in our country. I hope Dr. Mallikarjun is going to do justice.
I'd like to thank Dr. Anil and Dr. Srini for this opportunity. Acanthameba is an ubiquitous organism. It is found anywhere. It is found in soil, mud, and even you can find it in this room also. So whenever it gets opportunity, it invades the eye. So if you see the life cycle of the Acanthameba, it is present in two ways: the actively multiplication of multiple form of trophozoites, and the quiescent form in cyst. The diagnosis of Acanthameba is usually missed or delayed. So that's how we treat it in other way, and also the patient's lifestyle and quality also will be affected. If you see the epidemiology, if you see this world map, Acanthameba is common in our country. It is not that uncommon, and only in India and somewhere in Africa it is highly prevalent. If you see in USA and other countries, it is less than India. So we have to consider Acanthameba keratitis in every ulcer we see. And if you see the literature, the risk factors, what they prescribe, what they write is contact lens. That is not there in our country. That you have to remember. So the risk factor in our country are exposure to contaminated water or soil or trauma. And other risk factors are warmer weather and poor socioeconomic conditions, which is our country. And the signs and symptoms of Acanthameba keratitis. So again, in textbooks, we usually read a history of contact lens wear, out of proportional pain, radial keratoneuritis, and ring infiltrate. That are not much seen in Indian scenario. So if you see, usually the Acanthameba enters at the epithelial level. It invades the epithelium. There it forms the epithelial keratitis. If you don't recognize and treat it, then it will form it progresses and form the ring infiltrate and all other form of keratitis. In early stage, it can present with punctate epithelial erosions, anterior stromal hage, numeral keratitis, and varial stromal edema. Just it can present with a stromal edema. In late stage, if you don't treat in early stage, it can present with ring infiltrates, necrotizing keratitis, or diffuse infiltrate keratitis. These are the early stages. In the first case, it is you can see just dendritic form. It can present as a dendritic. It will be commonly misdiagnosed as viral keratitis. And in the second picture, it is also Acanthameba. It is presenting with just a stromal edema, and it can also present as epithelial erosions and also keratoneuritis. It is very important to diagnose this keratoneuritis. If you see this edema and the radial lines, the marked arrow line, there are keratoneuritis. So the Acanthameba organism is traveling along the nerves, and it is causing inflammation, and will have a more pain. In late stage, it can present as a ring infiltrate and necrotizing keratitis. It can present in many ways. So many atypical ways it can present. It can present in a non-contact lens wear. It can be bilateral presentation. It can just present without pain. That you have to remember. And it can present after excimer laser correction, and also like a central toxic keratopathy. Differential diagnosis, as earlier speakers have told, it can mimic many organs like herpetic keratitis, fungal keratitis, bacterial keratitis, or even contact lens associated keratitis. Laboratory diagnosis is very important, as Dr. Savitri Sharma Madam has told. Simple KSOS mount, if you do properly, you can find out the Acanthameba cyst, and it can be stained with Gimsta stain and also Gram stain. In Gimsta stain, it looks like a blue round dot with surrounding white hollow around it, and that is the cyst it looks. And in the trophozoites, it looks like a inflammatory cells. And specific strains like calculor fight, acrid orange can also be used. And PCR and other molecular methods also can be used. And in confocal microscopy, you can directly visualize the organisms. Even cyst and tophaceous you can be organizing. It is specificity in sensitivity is 80 to 100%. And culture is classically non-mutant agar with E. coli overlay, because these organisms, they thrive on E. coli. So even in culture plate, you can see that when you put a E. coli, they can just travel towards the E. coli. You can see that line in the culture plate. Medical management is mainly aimed at treating, you should remember, it should be aimed at treating both cyst and tophaceous. So commonly used is biogonoids. It is more common, it is most effective against tophaceous, not so against cyst. And you have diabetes like propamidine and hexamidine can be used. Azoles voriconazole can be used. It is a cysticidal. And among aminoglycoside, neomycin can be used. Some authors are happy with monotherapy. Some authors are happy with a combination of PHMB and propamidine. And the treatment required for this acanthameba to cure is very long. So once you diagnose and once the ulcer starts healing, at least it will take 3 to 4 months to completely heal. And recently, miltefosine, which is approved for leishmaniasis treatment, is also shown to be very effective against acanthameba. This is the PHAB I commonly used, and it will be available in 20% solution as a swimming pool disinfectant. So I do a double dilution method. It is a 20% solution. We have to make it 0.02%. First, I will make it 2% by adding 9 ml of normal saline to 1 ml of 20% solution. From that, 0.1 ml of that solution is added to 9.9 ml of artificial tears or saline, and that can be kept for maximum for 1 week. And it should be stored in the refrigerator, not in the freezer. And this is the one case, acanthameba, classically presented with ring infiltrate, and laboratory it was proven as acanthameba. Then started on PHMB, it did not respond. Then we started on voriconazole, then it slowly started responding. Surgical management is done when it doesn't respond with the medical management. In early stages, you can consider DALG and make sure that all the infected area should be removed. Even the recipient bed should not have organisms or infected area. In advanced cases, you can go for PKP. And in healed acanthamenic keratitis, wait for 6 months to do a optical PKP or DALG. In conclusion, AK is not a rare. Always keep in mind as acanthameba as a differential diagnosis in any infective keratitis, so that you won't miss that acanthameba. And early diagnosis helps in successful management. Thank you.
Thank you, sir, for that guidelines on the practical management of acanthameba keratitis. And thank you again for sticking to time.